Sarah is on her way. Here she is.
Hi there. I've reviewed Bill's chart. Looks like he has several new risk factors that we'll need to take into consideration as we reevaluate his treatment regimen. Here are the possible regimens that we could choose from, including his current regimen.
That's quite a list.
Yes. I see 4 possible options that could be appropriate for Bill's situation.
So we'll use the first A orb to select your preferred regimen for Bill.
Exactly. Then we'll have 3 more B orbs to use to identify the 3 additional regimens that are acceptable alternatives for him.
Our first decision. Are you ready?
This is a reasonable choice.
But bictegravir and tenofovir alafenamide are associated with weight gain, and TAF is also associated with increased lipids compared with TDF.
They are, but this can be monitored. Still, we should discuss the potential for weight gain with Bill. Bictegravir can be used with metformin without dose adjustment, since it only slightly increases metformin levels. It has less effect on metformin than dolutegravir.
Huh? But what about the TDF? Because this regimen contains TDF, it's probably not a good idea to have Bill continue taking it, considering he's at a higher risk of renal dysfunction.
I agree. Although this regimen is not absolutely contraindicated, it's not the best choice. If Bill's eGFR begins to decline, he would definitely need to be switched to a different regimen. In addition, efavirenz can cause neuropsychiatric side effects and has a low barrier to resistance.
What if Bill wants to stay on this regimen, since he's done well on it for so long?
If he strongly desires to continue on this regimen, we could keep him on it, as long as he's not having any side effects, and we've had a discussion about the pros and cons of switching.
Huh, I wouldn't have thought of this one.
Although this 2-drug regimen may have a lower barrier to resistance, the TANGO trial, which was presented at the 2019 International AIDS Society Conference, shows maintenance of viral suppression out to 48 weeks with no resistance.
So we have 4 possible options to switch to, and none that are absolutely contraindicated.
That's right. Here, you can see which treatment your peers preferred.
I really thought it would be easier to narrow down these choices.
A year or 2 ago, the best options would have been clearer. Switch to dolutegravir or bictegravir plus TAF emtricitabine. However, now we know there are data that suggest a potential for weight gain with dolutegravir, bictegravir, and TAF. And additional data are available on the use of 2-drug regimens that exclude TAF.
If we switch from TDF to TAF, it only decreases the risk of renal toxicity. It doesn't eliminate it.
I agree. And we have less clinical experience using 2-drug regimens. It's likely they have a lower barrier to resistance. There's a lot more nuance to the treatment decision than there used to be.
I guess we should try to narrow down our options. Since we have a variety of options that we can choose from, what factors would help to narrow down the choices?
I have a thought. How about we ask the patient?
Of course.
It's critical to engage the patient in the decision-making process, identifying the potential side effects, pill burden, cost, and potential drug-drug and drug-food interactions.
Okay then.